My name is William Gali, and I'm Senior Program Advisor at Family for Every Child. Family for Every Child is an alliance of currently 42 civil society organizations in 38 countries. We have goals around preventing family separation, strengthening families, ensuring high-quality alternative care when needed, and protecting children outside of any care. Our members have a rich and unique understanding of the situation for children and families in local contexts, as well as potential solutions and effective interventions for improving children's care. As a global alliance, we work to ensure that more children can grow up safe and protected in families and be provided with quality alternative care when needed. Today, we are discussing about the importance of supporting mental health in children's care. And now I would like to introduce our panelists representing 3 of our Family for Every Child's member organizations. We have Rita Panicker, who is the founder and director of Butterflies in India. Rita started work in the area of community health and women's empowerment. She has a master's degree in social work from the Tata Institute of Social Sciences and a master's degree in development studies from the Institute of Social Studies in The Hague. And we have Claudia Cabral, is the executive director of the Brazilian Associação Terra Homens. She's a psychologist, family therapist, and postgraduate in pedagogy from the Catholic University of Paris. Claudia is a founding member of the National Movement for Family and Community Coexistence and member of the Consultative Council of the Latin American Network Family Shelter RELAF. And we have Chaste Uwihoreye, is the country director of Uyisenga and Imanzi in Rwanda. He's a clinical psychologist working with children, youth, and families in Rwanda. Chaste is trained in trauma healing, individual transformation, family cohesion, community participation, and team and peace building. We welcome 3 of them. And the agenda for today, I'm going to just set a little context to what family is doing in terms of therapeutic approaches. And then we'll have Rita talking about the importance of mental health. Then after that, we'll have Claudia talking about the approach that ABTH organization is using. And then Chaste will speak to us about the narrative therapy within the intervention with children and families. After that, we'll have short breakout rooms to discuss a couple of questions, and then you can meet each other. And then we'll come back with a few insights from the breakout rooms and then open for discussion and questions and close. We have around 90 minutes. Just a little bit about Family for Every Child and therapeutic approaches. Therapeutic approaches was one of the key themes in Family for Every Child's program strategy. In the new strategy, together with 4 prioritized themes: sexual violence, children on the move, children in conflict with the law, kinship care, mental health has been promoted as a cross-cutting theme. Examples of key achievements in the area and how we will build on them. First of all, we had documented members' therapeutic approaches and shared with members and wider community. We're almost finishing a participatory action research, delving deeper into 3 approaches that members are using in Guyana, India, and Rwanda. And then there's a group reflecting on what makes our work therapeutic. This is work in progress. Just to talk a little bit about the documentation. The documentation captured members' first-hand experiences of therapeutic interventions and specific approaches they were using in working with children. Family members are applying a variety of professional approaches, such as social casework, community and clinical psychology, family therapy, and therapeutic counseling in extremely difficult contexts, and so on. I'm not going to define what is therapeutic approaches of mental health, but a broad definition of therapeutic interaction adapted when documenting the practices recognized that it is not always a formal therapy that leads to change. The way children and families are approached, the care and respect with which they are treated when in distress or difficulty, the relationships that are nurtured and sustained involvement, which demonstrates a commitment to care, can result in shifts without manualized or structured interventions. Therapeutic interactions, mental health support, or emotional support to children are therefore those that contribute to a mental, physiological, or emotional state of being regulated more healthily, a thought of feeling more bearable, something different happening in somebody's emotional life, someone having a better story about themselves, someone understanding themselves differently, something being tolerated, someone establishing or re-establishing contact with self and others, an experience being taken in or used more healthily, and the therapeutic relationship contributes to and change that lasts beyond the relationship ending. Recognizing these interactions is critically important, and the documentation we produced concentrated and emphasized the more formal interventions being offered. That being said, members are using a variety of approaches, tools, and techniques in support of emotional health of children. In today's webinar and the following two webinars in October and December, we will provide the opportunity for family members and wider practitioners a chance to reflect on the importance of supporting mental health needs of children and families by sharing the approaches that have worked for them, especially with children in the thematic areas that family focuses on. Now, there are some opportunities within this. Defining, sharing, and hearing what is mental health and what others are doing will build confidence among practitioners that they can start something somewhere and understand what staff can do and when and where a child needs.
Desde los que podemos
Quando a criança necessita.
And we know that during COVID, many Family for Every Child members have acted quickly and sensitively, and much can be done within the capacity the organizations already have. And we can also identify capacity building needs of staff at all levels, especially the social workforce, and learn from one another where resources are restricted. And then finally, advocating for more support from well-wishers, donors, and the government. I'd now like to turn to you, Rita, and invite you to share your perspectives on the importance of mental health. Rita?
Yes. Thank you, William, and a warm welcome to all my colleagues from the rest of the world. Is good morning, good afternoon, good evening. So the last 2.5 years have shown us the importance of the mental health. In fact, the pandemic has shown the importance of mental health in the lives of people. The unprecedented situation due to COVID-19 impacted children and adolescents in several ways as to how they learn, play, behave, interact, and deal with situations. There are innumerable studies done by different mental health professionals across the globe. Classic public health care interventions have focused on immunization, vaccinations, neonatal health care, nutrition, safe drinking water, and accessibility of primary health care. Their emphasis has been on curative and preventive disease-free health care. Mental health has not been part of public health care program in most countries. Mental health is not only mental health disorders, but also coping with emotions and situations. Today, we realize the importance of holistic health, including mental health of a person. Mental health care should be part of all our work with families, children, and communities, including the schools. The emotional well-being of children is important if the child has to grow up to be a self-confident person, is able to take informed decisions and resolve conflict through dialogue and discussions. The family has to be a caring and protective environment for a child to grow and thrive. We have analyzed child protection through the lens of children in crisis, failing to address the fundamental issues of a family in crisis. Patriarchal values, domestic violence, substance use, single parent, economic distress are some of the issues that lead to a collapse of the family. In such an environment, a child's emotional well-being is at risk. What we require is a systems approach. Therefore, wherever necessary, family therapeutic care should be part of the interventions. Mental health programs should not work in a silo, but cut across all interventions of the organization, irrespective of the target group or specialized area of work, be it education, healthcare, life skills, livelihood, sexual violence, or domestic violence, or any other, even human rights for that matter. For long, we have underestimated the importance of emotional well-being of a person. Mental health is not only mental health disorders, as I mentioned earlier, or psychiatric illnesses, but also supporting a person to handle grief, separation, anger, disappointment, lack of confidence, involvement in risk behavior, substance use, and so on. The therapeutic approach may differ based on the expertise of the organization, the target group they are working with, the cultural and social context, the issues being addressed, and the appropriateness of the psychosocial therapy. Technology and its impact on children. It has a major impact on our lives. The ramifications of children using internet for long periods unsupervised has resulted in an increased number of children being trapped in dark websites and chat rooms, resulting in online sexual abuse, which at some point becomes offline sexual abuse. A study done by Key and others in 2020 regarding this excessive use of internet by children mentions that raised agitation, aggression, anxiety, depression, sadness, and worsened school performance are some of the emotional issues reported among children worldwide. Social media platforms is another area which is used to express their unhappiness and distress. There are evidences of adolescents being bullied and shamed, which has resulted sadly in them taking their lives. The UNICEF 2021 report mentions that an estimated 45,800 adolescents die from suicide each year, and the age group is between the ages of 14 and 19. In the coming years, my friends, socialization patterns, human relationship will depend or rather revolve around technology and its influence on our lives. In these challenging times, the mental health and emotional well-being should be central in our engagement with children, adolescents, and family. There cannot be any other more important thing to do than to help our children to be emotionally well. Family for every child's position is that there should be a continuum of care for children, from family, community to school, if we want our children to thrive and be emotionally well. And this needs to be emphasized. And I like to stop here because I know we have two excellent presentations, and I'm sure we'll hear more about the importance of mental health in the lives of children and families and communities we work for. Thank you.
Thank you, Rita. I think you gave us a clear context, not only in the importance of taking care of emotional health, but the urgency and how we might start, and to keep in mind the continuum of care. Now I'm going to invite Claudia. Claudia is going to share her slides. Claudia.
I'm going to introduce myself. First of all, I would like to say that I would prefer to speak in Portuguese. First of all, because I have a bit of a cold. And secondly, all of my friends that are from Brazil that are here will be able to hear directly from Portuguese. And also the quality of our interpreters, and they're very good. And maybe I can speak a little faster and with more of a flow in Portuguese. So thank you so much for your interest in this theme. I have been working in this area for many, many years, and I think that this is one of the most important themes in our work. Family for Every Child has created a work group about this issue of therapeutic intervention, and I understand that it is not, after what William and Rita have said, it is not by chance. It is a huge need that has risen now recently after the pandemic, because people that are isolated inside their house, living very close to each other without much contact with other people, it ends up that the conflicts grow. And we know that external pressures influence the family and the functioning and the communication within the household. And that is what I'm going to talk about, because I'm a psychologist by profession, and Rita is as well, and Chaste is also a psychologist. And so we all have this training in psychology, despite we work, but besides working a lot in health and social welfare as well. And that is the place that I'm going to speak from. And I will now share my screen with you. And I would like to ask you to confirm if you can see my screen, please. If you could just confirm for me, please. Yes, can you see it?
Yes, Claudia,
yes.
Can see.
So this is the first issue, is that psychology is dialoguing with social assistance. So I am speaking from ABTH, but I understand that it's speaking from a place for most people that work in our area. That is the area of social protection, of the system of social protection for children and adolescents that are in a vulnerable situation. So this emotional support, the psychology within social assistance, has become a theme that has become really important for ABTH, for the institution in which I work at. And I will share with you this experience. So the principles that organize us, it's that not all vulnerable families necessarily have domestic violence. Not all poor families that live in very poor material conditions and also low educational conditions necessarily have domestic violence. The protection, the social protection system that deals with these families, these vulnerable families, they should introduce psychology as a way of working all of these issues in a therapeutical way. But then what is the difference from the clinical psychology? That is our issue. So social problems, they can influence the situation, the emotional situation of the individual, but it is not a condition for necessarily for the domestic issues, especially or necessarily in the families. And that's where we are specialized in ABTH. We work with families. So in the last 50 years or so, many theories have arisen in psychology about how to deal with violence that comes from the family, that is born within the family, but is very much affected by external violence, structural situation that affect the family. And many times within the family, we have negligence, abandonment, etc. And there are many theories: trauma theory, neuroscience, systemic theory, the attachment theory, psychoanalysis. I'm going to speak a little bit more about these and on what we are based on. And our curiosity, let's say, here with you is which of these theories would underpin your work to deal with the emotional issues of the children that you work with. So in our case, in ABTH, more than 20 years ago, we, based on the attachments and the so the system, it considers the interactions between all people. It works a lot with the dialogue. So we have the interpersonal dialogue. We have the dialogue between amongst people within the family. We understand that the family has a certain system that lives within another system, which is a community that is in a even bigger system, which is the society. So we have many subsystems that are interacting and dialoguing amongst themselves. And all of this has to be considered when we work with an individual that is living, that is experiencing very serious issues, mental health issues that will compromise development. And most of the cases that come to us. NGOs that want to deal with these vulnerability issues of domestic violence. So these elements, these systemic elements, they have an interaction amongst themselves that form a whole. And in this line of communication between elements, that is where our work is centered. And it has been centered on this for a long time. And when we started working with them in the social area, we found, and then now I have to talk a little bit about the environment, the Brazilian environment, the Brazilian culture, which is a culture that is very much Jew-Christian, based on Jew-Christian religion, and based on violence and poverty. We have many favelas with a lot of violence, with drug trafficking and poverty in rural areas, especially a lot of lack of resources. There's a lot of diversity and distance between poor and rich. In this context, we find an area of protection for children protection centered very much on the difficulties, centered on what was lacking, a negative view of what is the problem, a view that was very centralized on the professional knowledge, a lot of judgment, and a welfarism view of charity. So when we introduce this idea of dialogue and communication between the parties, we introduce a vision of group, a vision of relationship between people, focusing on the competences of people, the empowerment, giving people power, a positive view, a view that is centralized more on what the individual and the family system is bringing in terms of information than what I am observing from my paradigm. So putting yourself in the other person's shoes and giving them this power, empowering them. And from this, in this moment, the relationship between the professional and the family is extremely important in this work of mental health and emotional support. And I would say that it is not only in mental health of the child and the family, but also of the professional. So what makes our work therapeutic? What makes it therapeutic is the fact that we create situations in which people that are within the system, the professional and the child and the family, that they can reflect about themselves, promote self-knowledge of the person, of the professional that is working in that area, and also of the family, and enlighten this through and focus on the positive side to ways out of problems. So the biggest contribution would be a more higher consciousness of oneself, a certain self-analysis about how am I functioning here in this world for myself and for others whom I live and work with. And this is a reflection that professional needs to do for themselves, for them to be able to have this reflection with the family with whom they are working and the members of the family who should be protecting that child. So we then created a method of work, a work method. In these last 20 years, we're very much centralized in this vision of promotion of a therapeutic relationship of help towards the other person to know themselves. We have done more than 10 projects because an NGO has temporary projects that are financed during a certain period of time. And we've done this with many different situations. Children, street children, for them that are reintegrated with their family, children that are in shelters, that are coming back to their families, reintegration, prevention of separation. So when the child is about to be separated from the family before putting before the family goes to an institution, we work with the family as well. And then after, in the reintegration process. And then so all of the problems that generate the child leaving the family, so migration, street living, armed conflict, any of these problems can come to our team because our team knows how to work with a family independently of the problem that brought the family to us. So how to work with a family is what I'm going to speak about now quickly from our experience. So we put a social worker and a psychologist working together because there are two professionals that have two versions and personal filters that are different. So then they can interpret and analyze what they are seeing in different ways. And that helps us. That helps having two people and having two professionals that complement each other. So each of these pairs can work with up to 20 families, 20 cases, up to 35 children, because they might have brothers or sisters and all of the siblings are affected. So a lot more children than families. And throughout these 10 projects that we have worked for throughout the 20 years, we always have 80% of success in the reintegration of the child to their home and the reduction of the violence. We had 50% of success in some cases that were more difficult. When I say ideal conditions here on the slide, it's because, let's say, because we had some issues with the pair, the professionals would change, or the family would move around too much. But anyway, this was a methodology that worked, and our challenge is to help the federal government to implement this as a national policy. In some way, today, psychology is already in social assistance in Brazil. The system of social protection already has psychology as a necessary profession within social assistance. And we recognize this as a huge success. But I think that this working group that is here in family and this discussion here today is exactly that. What is the role of psychology within social workers, and how can we, social assistance, and how can we develop this? So this part, concrete part of work, we do a lot of home visits, a lot of contacts with the families in their homes, interviews with some members of the family, groups of families, and a lot of partnerships to be able to refer the patients, the cases to the patients. And we also do a reflective process in regarding the professional. And then we have two instruments that we have used throughout all these years, and they have been a big help, because when you look at a process of a child in the court, there's so many documents and pages, written pages, writing about the story of the child. But sometimes in one drawing, in one map, you can understand the whole situation, which is the genogram, which is the picture of the family, of that system. How does that system work? And many times, this you end up not helping the family therapeutically to reorganize themselves, because we don't do enough research of the family. And the family has the internal relationships, which is the genogram, and the external relationships, which is the ecogram. So here we have an example, the first one that came to us. And we have a family that had 4 children, a father, a grandmother, and a mother who had passed away. These 4 children were in an institution for over 2 years. When we started this case, we investigated the family, and we noticed that there are many more people in the extensive family that could support and take the children from the institution. And in the end, we had a huge universe of people within the family that very soon, in 4 months of work, the children ended up coming back to the family, and we continued supporting the comeback of the family, the reintegration of these children to the family during 12 months. So then after, we could leave and be sure that there would not be any more violence within this family. The other instrument is the EcoMap. The EcoMap shows the family and it's their relationship with the community and society. So it's a dialogue with the family that demands protection, and it participates within the society. Sometimes a family with violence closes itself and it doesn't go out to the community very much. So through this eco map, we work the family and their relationships within the society. The focus is also going away a bit from support and that can be more close to charity and go more to competence and empowerment of families so that they can be autonomous. The big challenge here, however, is how do we listen? How does the professional listen to the message of the family? How does the professional come in the family? What is the filter that the professional use that is inevitable because it comes from their experience? So this message of this filter in which many professionals end up, because of a power game of control game of judgment, they end up interfering in the change process of the family. That also is, the family is also coming with a low self-esteem, a certain confusion regarding external violence that they've been going through, with fear, with insecurities, with blockages. How do you promote this dialogue between the professional and the public, the target audience? So what would be the real active listening? So we work a lot with this self-knowledge of the professional and in terms of their decision to work in this area and their therapeutic capacity in order to make changes in the other person. So sometimes a professional sees themselves out of the system and they analyze the phenomenon that's happening to that child and to that family, but actually they are completely in the system. When he he is a part of the system when they start working. So they are also an extremely important person in this structure, and it's important that they also do their genogram and their echogram for them to know themselves, to help these children and family understand and know themselves even better. So I hope I was able to pass my message to you today, and that was my contribution to you this afternoon. Thank you very much.
Thank you, Claudia. You went a little beyond your time, but since it was interesting, I didn't interrupt you. But thank you for sharing about the work you do. I think the key points were not seeing a child as an isolated individual, but considering his or her context and the interventions between all people within that context. You also spoke about family as a system, the importance of relationship, how social workers, psychologists, family work together, and the concept of genogram and ecomap. And very good to hear about family empowerment. Thank you very much. Now I welcome Chaste about his experience of using narrative therapy within interventions with children and families in the context of his country in Rwanda. Chaste, Georgina is going to share her
Can you hear me, William? Can you hear me, William?
Yes, we can hear you, Chaste.
Thank you, William. I will try to be short and try to share my experience in working with families and children using narrative practices, narrative therapy. Probably before we go to slide, I just want to a little bit summarize what is narrative therapy, how it works, and what is its principles. Narrative therapy is one of the therapeutic approaches that has been created in Australia by Michael White. It's one of the postmodern psychotherapy. Narrative therapy has, let me say, 5 main steps to go through. The first step is trying to identify the action that can help professionals, practitioners to externalize the problem, to name a problem, to externalize the mental health problem, to name them, and to visualize them. And I will really emphasize that the narrative therapy strengthen the, if I can say, the contextualize of the intervention. The second step is the action that can help professional and the people, children and the families and the patient to deeply describe a problem. What the effect, the effect of the mental health on the person, on people, on the relationship, on the family. That's the next step. The third step is the step around the action that can help professionals, practitioners, as well as the people we are working with, to externalize the second story, the story of skills. The first story is a story of vulnerability, is a story of problem, but also there is another story, which is a story of skills. That is really why narrative therapy more focus on double story telling and double story listening. The telling the story of vulnerability, of problems, but also a story of capability and skills. And then the next step is the actions that help people, professionals and people, to deal with problem. How can we deal with the problem? If I call it like a depression and whatever, what action will I have to deal with that kind of that specific problem? And finally, what action that will help people to create the new story, the alternative story. That's another story, the second story I was talking about. So then I will a little bit share the experience. The narrative therapy propose the specific tools that really are culturally appropriate. Most are metaphors, others are culturally ways of working. That is why in my presentation I will talk a little more about proverbs, because in our Rwandan culture we use more proverb. And I will start by just introduction, the journey of using this narrative therapy. I will try to see how we use proverbs. And then we are going to talk a little bit about Rwandan healing journey with these narrative practices. And I will see if I can share one of the case study, and then I will conclude. Next, please. I will say that the narrative practices that have been used in Rwanda, it has been started being used in Rwanda just after genocide. You know, we experienced genocide in Rwanda around 30 years ago. And we are still experiencing trauma consequences related to that genocide and the other vulnerability event that followed genocide. So that's why we use the narrative practices. But before genocide, the family itself in Rwanda, it was structured in a way it could provide the healing, the therapy. That's why just after, if I can say, importing this, let me say, Western approach, that is clinical-based approaches, we didn't even words that we could use, because in our Kinyarwanda language, we don't have the concept like trauma, like depression, like anxiety, all of those concepts we don't have in our Kinyarwanda. So we had
I think Chaste internet is gone. Can others hear Chaste?
No.
Okay. While Chaste comes back, Chaste was trying to tell us the context of his country before the genocide, when even things like trauma were not spoken about, or they didn't even have the terminology. And after the genocide, mental health care in Rwanda before the mental health care in Rwanda used to be something done within families and communities. Then with the genocide, the whole social community and family structures were destroyed, including those regarding mental health. Then lack of words in the Rwandan language to describe the pains and suffering the people went through. The various symptoms that people experienced were thus named trauma. So there are limits of using such names, as they might not fully translate the nuances within the Kinyarwanda. You can see the next slide. I hope, Chaste, when you come back, you just let me know. And Chaste was supposed to share his experience about his journey, his own personal journey, his internship at ABTH, an influential association of widows. Then Chaste also is talking about the importance of using local languages to describe pains and suffering. We will see that in the proverbs that they use. The power of elder wisdoms and resilience. So he's talking about why not also go back to our traditional ways of speaking and talking. Next slide. I think the proverb itself is quite in itself straightforward. I will not be able to read this in Kinyarwanda.
Yes, can hear you, Chaste.
Okay. Come back, Chaste.
Chaste needs to go into the English channel, please, Chaste.
Apologies. The Chaste is coming back. And please, Chaste, go back to the English interpretation.
Can you hear me? I think now I am on the English interpretation.
Yes. I went through the other slide. Can you go back to the previous slide, Georgina? Yeah, can you go from here, Chaste, please?
Yes, thank you. As I was saying, the narrative therapy tried really to identify, contextualize, and culture-appropriate ways. As I told you, the first step is if I can say, identifying a problem, externalizing it from a person, because even the first and the main principle of narrative therapy is to separate a person from a problem. A person is a person and the problem is a problem. So there is this Rwandan proverb that say, that means that when you identify, you are farming and you are able to identify a stone in your field, that one will never damage your home. So we went through that proverb, and we should now identify and externalize and name the problem. So the significance, next please, the significance of proverb and the cultural appropriate ways really resonate and give names for problems. Just to give you an example, most of the names that are really identified named, most of the time they don't get the DSM names. Most of them are the cultural appropriate names, such as darkness. You will find like darkness. You will find like hopeless, like those really culturally appropriate name, and as those different names said. So next please. So as I said, there is those 5 steps that narrative therapy try to go through. The first step, which is trying to discovering the problem and naming it. And there are different exercises that are proposed by narrative, and even some local knowledge and skills from culture. For example, in Rwanda, we have different metaphor, naming a problem. That's an exercise. A time when my heart was open, that's an exercise that can be used. And then the second step is just to consulting, to have an agreement with people, with children, families, to go through that journey of healing. And there is another proverb saying, together we can get a solution. Then the next step, which is now dealing with a problem. In narrative therapy, we deal with problems, we don't deal with person. So in dealing with problems, the narrative therapy also propose different tools like Tree of Life, like Themes of Life, writing letters to the problem, Garden of Hope, House of Life. All those are metaphors that help people now to heal, to separate a problem from a person. And then we come at the last, which is ceremony, certification. When a person is no longer living with a problem, the narrative therapy propose a kind of enjoyment, even a certificate. So this is a kind of, if I can say, framework of narrative therapy. So the other, next please. That is what I was explaining, discovering the problem using those kind of proverb in the Rwandan context. And I think in the other countries also, it's sometimes easy to find its own ways, its own practices that can help. For example, in this, we can use a paper, drawing, image, name, and this and all these exercises can be done, let me say, both individually and collectively. We can name, let me say, a problem individually, but we can also name it collectively. And then we agreed on the healing journey. Next, please. Next, please. So I will say that after identifying a problem, we have to deal it. We can talk to it. We can write a letter. We can identify now resources. We can identify skills. And also, as I said, like those letters, both individual and the collective letters, those are the simple materials and the simple tools that are proposed by the narrative therapy. And finally, next please. Finally, as I said, the narrative therapy proposed to create a second story, another story. If we are talking about, for example, a story of street connected children, we have to create another story, which if we name the problem like streeticism, because in the narrative therapy, we don't use those DSM names, we have to find another thing that should replace that problem after separating completely with a person. If it was a darkness, probably we can find a light. If it was a fear, we have to find another replacement. Next, please. And then, as I said, after getting that replacement is where we celebrate, we enjoy, we provide a certificate that a child is no longer a street child, a family is no longer living in conflict, and we provide, if I can say, a certificate called Certificate of Life. So just to end my intervention, I will say that we have been using these practices in different ways, with families, with children, with communities, and it's easy even to use individually. There are some cases that we have been using, and I think probably we will share. I want to say that in psychotherapy, most of the time, it's not easy to tell people how to do it. It's more easy to show how to do it. In psychotherapy, I like to say it's not easy to read how to do it. It's sometimes to see how to do it. So thank you very much for this time. Thank you.
Thank you, Chaste. Thank you very much for your personal touch to this presentation, looking at mental health from the historic trauma context of Rwanda genocide. I like the proverbs that you use and the steps in narrative therapy, identifying, discussing the problem, naming it, and then immersing into the healing process, and then writing a new story, and then celebrating, and doing all this through very simple and straightforward things that are available, writing, storytelling, etc. Thank you so much. Now we had planned to do a little discussion, but we will come later on. We are going into breakout rooms. We thought that since there are a lot of practitioners with a lot of experiences, your own experiences, who are members of family and who are not members of family organizations working with children, for 10 minutes, we will now divide up into breakout rooms. Georgina will kindly help us. We have two questions, actually some really pointers, not questions. You can choose any one of them. I have that on the slide. I will share with you those two questions. One of them is to, sorry, I'm just coming back here.
We'll put them in the chat too.
What is your understanding, your own understanding of providing mental health support for children in care in your own organization? You can discuss that, or across the range of interventions or services that you implement in your organizations. Can you please share what would be one primary or key intervention or a tool or an approach that you use in supporting mental health of children? We'll also put that in the chat box. So Georgina, can you please help us to go into the breakup rooms? And then after 10 minutes, we are not expecting any one person to take notes, but if you can please keep in mind any insight or an experience that you think it is worth sharing with others in the other groups, we will do that. Thank you for coming back again. We just leave the floor open. There are two scenarios. Either you can share something that struck you from the breakout rooms, if there was any insight or an experience that you want to share with others. We can also ask questions to the panelists. If you have any questions, either you show your hand and ask your question, or you can put in the chat box. Yes, as someone saying in the chat box, nice to see familiar faces. Please unmute and come up with your question or something that came out in the breakout rooms. Yes. While we are waiting, there was a question to Claudia about the psychologist working with social workers. Can you please tell us, is the psychologist always accompanying the social?
¿Podrías contarnos
O ascenso
Together, do they work together with social worker all the time? Or how do they support social workers, or do they intervene at certain times? Claudia? Are you in your language channel? Interpretation, please.
I am on the English channel
Okay, please.
now.
Yeah. Please go ahead, Claudia.
For us in ABTH, as we are an NGO, we are able to choose what we are doing. We are not the government. We are not on the whole policy to be put in place for the whole Brazilian children. So it's easier somehow for us to choose what do we want. So for us, in our methodology, psychologists and social workers are always together. And we learned that long years ago, that the filter is less subjective and more objective when you have two people listening to the same thing. And there is a very good complementation between the social welfare or the social regard in terms of possibilities that are offered, concrete possibilities that are offered to the members of the family, and the psychologist regard that is to see the feelings, to understand the dialogue and the relationship, a constructive relationship between the members within the family, a protective relationship between the members within the family. These are two complemented approaches, and for us in ABTH, it's very important that they are together. I think psychologists are still thinking what are their place on the social welfare system, because in university they have not been studying to work within the social welfare system. In Brazil, it's much more centered on the clinical side than on the social side. So this is a learning that I think we here in this group would like to develop and to think really about it, the role of the psychology within the social welfare system that has a limit, has a period. It's not to go so deeply as a psychoanalysis, a clinic setting. It's not that. It's something different. And I profit the opportunity to say that in our group, we were discussing, and there was some very good examples centered on different theories. For example, neuroscience is one of the theories that on our group, Teresa from the World Vision was saying. She was in Ukraine. Perhaps Teresa could say something on that. And expressing the work with art, somehow the same as Chaste said, with art, with music, with dance, and behind the art, we can raise a lot of feelings. And here on the psychological side, we are talking about feelings. We are talking about emotional side. Well, I hope I have answered your question.
Yeah, thanks, Claudia. Teresa, do you want to share something quickly, or does someone else have anything more to add? We also had Karen in our group who spoke about parenting and the pleasure and initiative that supports parents.
Sure. This is Teresa Wallace from World Vision. I can just speak just for a minute. Sorry, I cannot use my camera. I was just sharing about an approach that we use from First Aid Arts, using expressive arts that has an underlying theory of neuroscience. We use it with adolescents as a universal prevention model that helps to strengthen the adolescents' resilience by helping them build their own self-awareness and skills to help them emotionally regulate. So using these different techniques, very, very simple ones. From art or music or movement that are culturally appropriate. And so I've now seen it used in our Ukraine response, as well as in Jordan, as well as in Venezuela. So culturally adapted. And then Chaste made the great point that this could be integrated within narrative therapy. So it's not just a standalone, but the type of thing that works well within other approaches. Thank you.
Right. Thank you so much, Teresa. We have another few minutes if someone had anything to add.
Can I just add one point?
Please, Rita.
I think what Teresa said, because in India, there's another therapy, which is art, music, movement, and dance therapy. And the movement and dance therapy, in fact, I think is one of it is part of a course now in Tata Institute Social Sciences as part of the social work curriculum, where they are teaching a movement and dance therapy. And this is normally used for what they have got a lot of evidences is working with teenage girls who were trafficked and had been pushed into commercial sex work. And then from that, so that is another, I would say a therapeutic approach that is worth understanding. But everything is based on cultural and the target group that one is working with. Yeah.
Thank you. And we are going to invite some people in the October and December webinars to talk about these more creative arts that are being used. Thank you very much. And actually, we are approaching the end of today's online event. But before we close, I would like to reiterate that we will be running 2 more webinars on this topic in October and December. And we might have more people who are not members of Family for Every Child and Family for Every Child. It will be more sharing about the specific interventions. I also want to mention a community platform for child rights practitioners called Changemakers for Children. Most of you will have registered for this event through this platform. So this is a space for local practitioners to come together, connect, collaborate, and communicate, to learn from each other, about what's working on the ground, to participate in discussions, solve problems, participate in advocacy initiatives, and engage with and influence the wider sector. So if you haven't already, we really welcome you all to become active participants in this global digital platform with this topic, and many others are discussed frequently. Visit changemakerschildren.community to sign up. We will also post the URL. I think Georgina just did that. In closing, I would like to thank our speakers, Rita, Claudia, and Chaste, for taking time to share their work and insights, and to all of you really for taking time to participate in this.